Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City. Today we have something really special for you in honor of the 2019 annual meeting. We've selected a research presentation from each section of the meeting to be highlighted in the podcast. For each, we will interview the presenting author to discuss the study's findings and importance. Unfortunately, today my regular co-host Rachel Frank is not able to join us. To even try to come close to replacing her charisma, I've recruited 7 guest hosts, one for each of the included presentations. Before we get started, I should mention that the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, or any of the institutions of our guests. I truly hope you enjoy these interviews and that they enhance your annual meeting experience. I'm here with Dr. Brian Cole from Midwest Orthopedics at Rush. Dr. Cole, how are you?
Great. Thank you for doing this.
Dr. Justin Griffin from Virginia Beach is here as our guest co-host. Justin, how are you?
Doing great. Thanks for having me, Peter.
We are here to discuss Dr. Cole's project entitled Prospective Randomized Clinical Trial of Biologic Augmentation with Mesenchymal Stem Cells in Patients Undergoing Arthroscopic Rotator Cuff Repair. Dr. Cole, can you give us a high-level summary of this project?
Yes. This is a study that is a randomized, prospective, single-blind study to the extent that the patients have no idea which treatment arm they were relegated to, investigating the use of bone marrow concentrate in patients who have an isolated supraspinatus tear, treated with a generally similar technique using a transosseous equivalent rotator cuff repair, half of whom get an injection of bone marrow concentrate, half of whom get a stab wound over the ASIS, mimicking a bone marrow concentrate aspirate. And the primary endpoints are traditional PROs as well as MRI at 1 year.
So, Dr. Cole, tell us more exactly where do you put the BMAC? Between the tendon and the bone, subacromially?
So the study involves a complete arthroscopic rotator cuff repair followed by getting rid of any excess fluid within the subacromial region using a spinal needle, injecting the bone marrow concentrate between the tendon edge and the bony site of apposition.
And what were your main findings here?
So as I mentioned, the primary endpoints were PROs, traditional PROs such as ASES, SST, constant sane SF12s, but the study was generally powered for MRI evaluation at 1 year postoperatively using the SIGAIA score. So the outcomes themselves showed that in the patients themselves, we had equal response in terms of pre versus postoperative evaluation at 3, 6, 12, and 24 months using our PROs. But the primary significant finding was that the MRI at 1 year showed approximately a 1-point difference in the SIGAIA score based upon MRI evaluation of rotator cuff integrity. In other words, in favor of the intactness of the rotator cuff in response to patients who received bone marrow concentrate versus those who did not.
So first of all, congratulations on the study, Dr. Cole, and I definitely think this is sort of fantastic information for those of us who have a high interest in this. Certainly a timely topic and a lot of good discussion points. One question I had was, did you notice any association between patients who had a larger tear? Were you able to sort of parse that out in your study and your SIGAIA score and outcome differences?
So the premise of the study was to try to enroll patients with a fairly homogeneous pathology. So the goal was a single tendon supraspinatus tear and no other rotator cuff pathology. So that was the goal. So every patient had a less than 3 centimeter tear that was included in the study. If they were larger, they were excluded. So we took into consideration the fact that tear size might matter, and we tried to make a homogeneous population vis-a-vis the tear tendon size.
Did any of your patients have any postoperative symptoms from the harvest of the bone marrow aspirate?
No, I would say that, the good news is that while we can't assuredly say that there's a difference postoperatively in terms of clinical outcomes, and we have a modest change in terms of SIGAIA scoring, there were no complications related to the bone marrow aspirate harvest.
Do you have any advice for surgeons regarding ideal concentration or technique for BMAC preparation?
So another great question. I would say the following. One of the challenges of much of the research in dealing with any sort of biologic adjuvant to surgical intervention is that We are still, we have many blind spots in terms of the dosage, the frequency, the important thing is for studies like this to actually characterize what we're delivering. So in this study, we did just that. We took an aliquot of every patient who underwent a bone marrow aspirate, and we performed flow cytometry to look at the fold increase in nucleated cells that had receptor positivity or negativity that would be a representative of stemness. That being said, we don't have much information on dosage, frequency, and so forth. So this is what is clinically done in those who are interested in utilizing this technology. It's a pretty straightforward technique that involves aspiration of 60 cc's of bone marrow. As far as site and location, there is some data that suggests that the number of MSCs, if that's actually important, are highest in the posterior superior iliac spine, followed by the anterior superior iliac spine, and then distal femur, proximal tibia, and even proximal humerus. So all can be sites of harvest. The challenge is nobody has done any comparative studies. They've all been based upon either CFUs or colony forming units or a flow cytometry to identify, sort of what's present and how they perform in culture. That being said, we don't have any studies that actually tell us which one is actually better. So it often becomes a situation of convenience more than what we think we know, which is superior. In this study, just to be clear, we used the ASES.
One of the primary outcomes of your study is the difference in SGAIA grade. Now, were the people that graded the MRIs blinded to which group the patients were in?
Yeah, of course. We had 2 orthopedic surgeons who were blinded to reading both pre and 1 year MRIs just to categorize the tear size and the potential for recurrence. Yes, they were blinded.
So as one final sort of closing question, when you see the future of this with your wealth of knowledge in the area as a leader in the area of biologics in the shoulder, what do you see as the future of how we use stem cells and optimal delivery in terms of time zero biology and getting it there for our patients?
Well, yeah, so just, my high level opinion on this is that we first have to understand why rotator cuff tears occur in the first place. And the vast majority of rotator cuff pathology is sort of attritional or dystrophic in nature. Very rare do we actually see patients who have traumatically induced rotator cuff pathology or sort of overuse related. And even those patients might have sort of this genetic predisposition or diathesis. You and I know that, every decade of life we see an increased incidence of rotator cuff pathology, and it largely relates to sort of decreasing biology of the tendon-bone interface. And the good news is most patients tolerate it. It's estimated that we probably have about 6 million people walking around with rotator cuff tears over the age of 60 to 65. So we're not doing that many rotator cuff repairs. They're not showing up in our offices. We do 250 to 350,000 rotator cuff repairs a year in totality in the United States. So most patients tolerate it. And the thing that's really, I think, I find most fascinating is that we have spent a lot of time and energy on biomechanical constructs. In other words, trying to identify the best way to repair a tear, yet at 1 year we're shocked when we see a 20 to 40% re-tear rate. And unfortunately that hasn't changed over the last decade in any great extent utilizing modern techniques. So when you repair damaged tissue or poor quality tissue, it shouldn't be surprising that 1 year later that a certain percentage of these people actually have a re-tear, or whether it's a failure to heal or a re-tear, they have an anatomic deficit at evaluation by either ultrasound or MRI. So as far as where we're going, it may be MSCs, it may be, I think it's important to understand that these are not likely, the response is less likely to do with the terminal differentiating of cells, but rather related to a paracrine effect, a growth factor effect. Maybe it's modulating the immune system, reducing inflammation, all the things that impair a good, healthy response. But, we clearly need to do a much better job, and whether or not bone marrow concentrate as sort of an option that has a low regulatory barrier or some other technology that can help us either rewind the clock or improve the ultimate structural integrity of what we're trying to achieve. That's what we're looking for in the end game. So I think there's one step in the right direction. I don't think it's the complete answer, but I think at least, through this study, it's the first study that's looked at in a randomized fashion. Hernigau taught us or showed us that with a very high volume, high number of MSCs based upon identification, he was able to achieve a significant fold increase in terms of the lack of anatomic failure. This shows us in our study that we have about a 1 point difference on a 5-point scale, that patients actually have improved integrity of the repair site. But I still think we have a long way to go.
Well, Dr. Cole, it's a great study. It's a great contribution. I can't tell you how much we appreciate your insight, and I couldn't agree with you more that there's so much left to be done. Thank you both for doing this with me. This has been great. Take care. Have a great meeting.
Thank you, guys.
Thank you.
I'm here with Dr. Mirzayan from Kaiser Permanente, Southern California. Dr. Mirzayan, how are you?
Great, thank you.
Dr. Hartzler from San Antonio is here as our guest co-host. Rob, how are you?
I'm doing well. Thanks for having me.
We are here to discuss Dr. Mirzayan's project entitled Functional and MRI Outcomes of Superior Capsule Reconstruction with Acellular Dermal Matrix. Dr. Mirzayan, can you give us a high-level summary of this project?
Sure. We essentially looked at 53 patients who had an SCR done by 5 fellowship-trained surgeons over a 4-year period, and the main purpose of the study was to correlate functional outcomes with MRI findings. And most of the studies that are out right now do not have a lot of imaging post-operatively, and the majority of them report excellent outcomes with SCR, but we wanted to see if they correlated with graft integrity. So 80% of our patients got a post-op MRI, which is a very high rate compared to what's out in the literature right now. And surprisingly, we found that only 38% of the patients had an intact graft, and 62% had a graft tear. And we correlated the location of the graft tear with the functional outcomes. And those patients that had a tear where the graft covered the tuberosity, those patients did clinically well. The ones that had a tear where the tuberosity was left bare or uncovered, those are the patients who did poorly. And we did not find any correlation with hematograde, pre-op Goutallier, age, gender, or any other variable that had an effect on the functional outcome.
And how many of these patients had a concomitant treatment of the biceps with a tenotomy or tenodesis?
About a third of them, so 12 had a biceps tenodesis, 6 had a tenotomy.
So what do you think is the reasoning behind the patients with the covered tuberosity doing better?
That's a great question. I call this a biologic tuberoplasty effect, which we've published on. And I basically think that once the graft tears, it covers the tuberosity and it prevents bone-to-bone contact between the tuberosity and the acromion. So it acts as a biologic buffer, essentially. So that's how I think it still works, even though it's torn.
So I guess I would ask you, if you think that's how it works, and if only 38% of the grafts heal, have you considered just attaching the graft to the humerus or the acromion?
I definitely have, and it makes sense. It would make surgery a lot easier, but I firmly believe in the SCR because Tira Mihata has shown us biomechanically it restores the kinematics of the shoulder. So it keeps the head centered on the glenoid and keeps the center of rotation and centered with the glenoid. If you just cover the tuberosity, your head is still going to ride high, and the center of rotation is going to get raised because there's nothing on top, preventing it from superior migration. So I thought about it. It's easier, but I don't think mechanically it makes sense to do that.
So have you made any changes in terms of technique or post-operative rehab or anything to try to improve the healing rate?
Yes, absolutely. What we found is the majority of the tears occurred from the glenoid side. So I think what we're doing right now with our glenoid fixation is our weak point. So we all use 3 anchors in this series on the glenoid side. I think graft thickness is something that is definitely has changed. I personally, in my patients, I double over the graft. So I take a 7x4 dermal allograft that's 3 millimeters thick, and I double it over. So now I have a 6 millimeter graft. And anecdotally, it wasn't in our series, but in my last 10 patients, I've only had one tear. So just increasing the thickness of the graft has significantly lowered my tear rates and improved the healing rates.
One of the things that I think is interesting in this study is to ask what we do going forward. So I think from that I would ask, number one, how in your practice have these results compared to an arthroscopic debridement and tuberoplasty? And then number two, with these results, how does this procedure fit into your algorithm for how you treat massive cuff tears?
Sure. I personally have not really treated any patient with just a debridement or a plain tuberoplasty. It never makes sense to just go in there and clean something up. I mean, and the results show they're short-lived. They don't have a lasting effect. And obviously, we don't know the long-term results of SCRs. It's such a new procedure, but it just makes way more sense biomechanically to restore the kinematics of the shoulder. And Rob, to answer your question about rehab, what I've found over the last 4 or 5 years of doing this, patients don't listen to whatever rehab restrictions you've given them or the therapist. They come in, they're doing so well at 2 to 3 months after surgery. They're showing off and they're raising their arm all the way. And we know from the canine studies that at 3 months the graft is at the weakest point, and you should go slow with the rehab. But patients don't listen. They do what they want to do. So I've kind of given up on having a strict rehab protocol, and I think patients are still doing well.
Yeah, such an interesting study. I think it's such a great accomplishment for Kaiser, and such a gives us so much more information to try to determine what we do going forward with SCR. I really appreciate you coming to talk to us about it, and thank you, Rob, also for serving as, I guess, co-host.
Thank you.
Thank you. I just wanted to add one more thing. I think future studies, if they're looking at MRI, you can't just combine all tears into one group and compare it to intact grafts. You have to tease out where the graft tear is in future studies, so that they're not, you can't combine them. It's gonna give you poor results, essentially, erroneous results.
Certainly an important insight for us to understand what to do going forward with SCR. Yeah, thank you.
Thank you for having me.
I'm here with Dr. Schrumpf from the California Pacific Orthopedics Group in San Francisco. Dr. Schrumpf, how are you?
I'm well. How are you?
Dr. Alex Aleem from Washington University in St. Louis is here as our guest co-host. Alex, how are you?
Doing very well. Thanks for having me.
So we are here to discuss Dr. Schrumpf's project entitled Elbow Hemi-Arthroplasty for Intra-Articular Distal Humerus Fractures, Results and Technique. Dr. Schrumpf, can you give us a high-level summary of your project?
Yeah, so we went back and retrospectively looked at our patients in which we'd done elbow hemi-arthroplasty for. We identified 8 patients in our cohort. 5 of them had more than 12-month follow-up. In that group of 5 that we followed up, they had, on average, roughly 3 years of follow-up. On the whole, they had a Mayo Elbow Performance Score of 88 and excellent range of motion and high patient satisfaction. And we've seen this as an opportunity to avoid some of the potential complications of a total elbow arthroplasty in a group of patients that I would call kind of a young elderly group. And we've been very happy with at least our short-term results.
That's great. It's really great to hear about projects like these expanding indications. One of the things, when I read your abstract, you say appropriate sizing and length were determined by intraoperative fluoroscopy. Tell us a little bit more about that process. Tell us about your operative technique here for getting the size right.
Sure. So it's worth noting the implant I'm using is being used in an off-label way, first and foremost. And so I have a non-anatomic spool, but I am doing my best to fit that non-anatomic spool to the patient's native forearm. In particular, in that system, there are plastic spools that are not attached to other devices that are used for the bell saw in the ulnar resection there. They're radio opaque enough that you can see them on a fluoroscope. And so I take them and I put them into the native forearm once I've removed the fracture fragments and gotten ready to do it. And I will look and see where the capitellar contact is when that spool sits in the fossa for the ulna. And I go to pick a spool that appropriately fits to the capitellum in that I feel like it's going to be stable. There really only are, I think, 4 choices in that system. And so you're often picking between either too big or too small, and you have to make a compromise. But you can clearly center in on what you think is the most appropriate size based on the contact and how it seats, and whether or not it's stable as you put your hands on either side of the forearm.
You mentioned the limitations in size. Do you find yourself generally, it's a small group, having to oversize the spool if you're in between sizes versus undersizing? Because when you're doing a total elbow with that system, the general thought is to undersize because then you can get a better radiocapitellar alignment, but the worry with that would be potentially loss of stability. So
I tend to feel like because the spool size dictates the stem size,
right,
and many of these patients are fairly osteoporotic females, I will, if I'm going to pick between the two of them, I tend to pick the smaller size as long as it looks stable and as long as it fits.
Right.
And if you look at a normal AP radiograph of a forearm, the contact area, the radial head often hangs over the edge of the capitellum some, and so you're not looking for something that gets all the way out to the edge of the radius. You're looking for something that gets out to like 85-90% of the radial head, if you think about the way a normal AP X-ray looks. And after a ligament repair, they're often substantially more stable, right, than they are just when you put the implant in. And so it's important to think about what your stability is going to be like at the conclusion of the case and not just at the end of the implantation process.
Tell us a little bit about how you're repairing the ligaments.
So the ligament repair, I think, is actually the critical part to getting this to work well. And in my approach, as I'm taking the ligaments off of the epicondylar, off the medial and lateral epicondyles, I tag them with a number 2 non-absorbable suture. I start from the intra-articular side with the free end of the suture leaving a substantial tail. I use a modified Mason Allen, so I pass out through the ligament, I pass back, and pass that over again the suture. So now I've gotten a really good hold on that, and I clamp it with, probably, 10 centimeters of whatever it is, a substantial length of suture, because I'm going to pass that back through the spool. I do this on both the medial and lateral side, so I've got the ligaments secured right when I took them off the isometric points. After I'm done with the case and I've implanted the spool, I then take the metal passer. It's worth noting that their metal passer is the only one that I found that actually fits through, and a Houston suture passer or another passer device doesn't actually fit through the central screw. So I use their metal passer, and I pass the sutures from medial lateral to medial, and then I take a free needle on those sutures and I pass it over the common extensor tendon or the common flexor tendon origin and tie on the outside. But you can't tie one until you've passed them both. So it's a very stepwise process, if that makes sense.
Yeah, absolutely.
So, first you identify the ligaments, then you do your case, then you pass your ligaments through the spool either way, then you pass your ligaments through the common extensor, common flexor origins, and then you tie.
And then the ligament's obviously not healing to the implant. Where do you think the stability comes from? Do you think that the ligaments then heal common flexor, common extensor, and that's where you get stability, is up the columns, or?
I think it comes from a number of different factors. I think where the epicondylar tissue remains, I think it can heal to bone.
Yeah.
I also think from my experience doing revision, both elbow arthroplasty and shoulder arthroplasty, that most people generate a pseudocapsule that's fairly robust around a metal implant. Yeah. It doesn't necessarily heal to an implant, but by doing this, I think you kind of dictate the size and laxity of that capsule. Mm-hmm. This tissue is quite robust when you take it off, and it's quite obvious what it is when you take it off. If you don't tag it, it's pretty easy to lose it in your surgical field, which is why I tag it when I take it off as opposed to trying to find it at the end of the case. And I think it kind of dictates the size of that pseudocapsule. And where I can, I'll repair the epicondylar tissue, but where I can't, I rely on that pseudocapsule, which is part of the reason why I do that protected overhead range of motion protocol, to try not to let these people stretch out in the first month or so where they're running around. I don't have them just ranging their elbow in a hinge brace. I got that hinge brace locked for the first month. I have them coming out, lying on their back and working on their range of motion so they don't lose their flexion extension access, but trying to get them kind of to heal in and scar in enough that I feel like they're going to be stable.
Going back to the epicondyles, I think traditional teaching with this is you have to keep the epicondyles in order to give either bony healing for the ligaments or provide support. You mentioned that you don't necessarily keep the epicondyles. Is that based on just comminution? Is that based on just sort of availability? And it seems like you don't really notice a difference with your protocol in terms of instability of these patients.
Yeah, so I haven't noticed a difference in the patients. Where I can, I put it back because it makes me feel better, makes me sleep better at night.
Yeah.
But not infrequently, I found myself with a small splinter of bone representing the epicondyle, not feeling like putting a screw in it's going to be very helpful. And you've got a sclerotic kind of dead piece of epicondylar bone that's not attached to any soft tissue. And whether or not you put it back with a couple of cerclage sutures or other things, I don't think is going to dictate what's going to happen to it. And I haven't noticed additional instability. It's worth noting, and we mentioned it yesterday in our slides, we did have one instability patient and a patient who had a ground level fall subsequent to this. And she had a elbow dislocation subluxation event, which was easily converted to a total elbow arthroplasty. I think that this is obviously not as strong as a native elbow, and it's not going to be as durable as a native elbow, and it's going to have different modes of failure than a linked prosthesis. But in regular everyday use, I haven't seen these people becoming unstable. That's not to say that at 5 years or 10 years they won't develop instability.
You mentioned that it's not a normal elbow. If someone's 1 year out from this procedure, do you give them residual limitations, or do you tell them they can do what they'd like?
I tell them that I would prefer if they didn't want to participate in things that I think are high varus valgus activities like a tennis or golf or other racket sports where they're going to, and I have this discussion with them preoperatively about, I worry a little bit about these things, but I would have a similar discussion with somebody if I was going to put a total elbow in.
Absolutely, yeah.
But I don't give them a formal weight restriction as to what they can lift, push, or pull as I would with a total elbow.
I think that's a great point in terms of that as well, because you still worry about arthroplasties, but I think the weight restriction is a big attractive factor about this.
It's life-changing for
it's
patients.
Completely, yeah. I mean, if you think about my patient population, probably a little bit less active than yours in San Francisco, but still people that are using their arm just to get themselves out of bed. And a total elbow scares me every time I put it in because I know that they're pistoning on that daily just to get out of a chair. So they're not going to be playing tennis, but they are going to be putting a lot of force through that elbow. So I think this is a really, really great study to kind of show a creative way to solve a tough problem.
Have you seen any, I know we have early results only, have you seen any signs of ulnar wear?
I haven't seen any patients who developed ulnar wear in this acute traumatic population, no. They've all done fairly well. Their pain scores have not been creeping up over time. That being said, it's still a hemi-arthroplasty, and they don't report zero pain, perfect elbow. They all kind of, it's good, right? Which is what I would expect out of a hemi-arthroplasty scenario.
Mm-hmm.
In terms of, you talked about, you talk to these patients pretty extensively preoperatively. What's sort of your decision point when you're talking to them or for them between a total elbow versus the hemi-arthroplasty? Is it mostly activity or is it a little bit of a balanced discussion with the patient?
It's honestly, it centers more on what I foresee the kind of patient's remaining quality years of life looking like. In my mind, a total elbow arthroplasty is a very solid operation for somebody who I think is going to use it for 5 to maybe 10 years. And at that point, I begin to worry about the revision burden. In a patient in whom I believe is likely to have a revision in their lifetime, I think a revision to a placement of an ulnar component only is a much easier revision than a revision with a periprosthetic fracture or a loose ulnar component or a fractured ulnar or humeral component. And so I see these patients as a first step to an eventual surgery. As a young surgeon in an area where I think I'm probably going to be practicing for a long period of time, I think I'm going to be looking after these patients. And so implanting a lot of total elbows in people in their 40s and 50s, even for terrible traumatic things, scares me quite a bit. I spend more of my practice doing revision total elbows than primary total elbows by a factor of 10 to 1.
I'm in the same boat as you. So it's that's a great point because the primary ulna is way easier than the revision ulna, and I've all seen total elbows done in younger people elsewhere. They come back and it's just a complete disaster. So,
well, this is it's a great study. It's great to hear about new and innovative thinking for difficult problems. And it's great to hear that it's working well so far. Thank you for doing this with us, Dr. Schrumpf, Dr. Aleem.
Thank you for the opportunity.
Yeah, pleasure. Thank you.
So I'm here with Rob Hartzler from San Antonio. Rob, how are you?
I'm doing well. Thanks for inviting me, Pete.
Absolutely, absolutely. And I'm also here with Dr. Brendan Patterson from the University of Iowa, who's here as our guest co-host. Brendan, how are you?
I'm doing very well, Peter. Thanks for the invitation.
So we're here to discuss Dr. Rob Hartzler's project entitled Radiographic Parameters Associated with Excellent versus Poor Range of Motion Outcomes Following Reverse Total Shoulder Arthroplasty. Rob, can you give us a high-level summary of your project?
Sure. So this was a retrospective database study where we investigated what factors were associated with having an excellent outcome versus a poor outcome, particularly with regard to range of motion after a reverse total shoulder arthroplasty. And we investigated a variety of different factors, both patient, implant, and radiographic factors, which was the main focus of the study. We found that there were a few factors associated with having an excellent outcome, which was defined as having at least 140 degrees of forward elevation and external rotation greater than 30, compared with a poor outcome, which was forward elevation less than 100 or external rotation less than 15. So what we found in the study was that a larger glenosphere and inferior overhang of the glenosphere were associated with having an excellent outcome, and glenosphere was highly significant with a 9 times increased odds for a 39 versus 36 glenosphere of having an excellent outcome, and a 5 times odds ratio of having an excellent outcome with a 42 versus a 36 glenosphere. For each millimeter of inferior overhang, there was 1.6 times odds of having an excellent outcome, and anterior offset of the humeral cup was highly associated with a negative outcome. In a univariate analysis, BMI was significant, but that didn't hold in the multivariate analysis. No, in this analysis, no measure of lateralization of the humerus or the glenosphere was associated with an excellent outcome. So that's what we found.
That's great. Rob, I just wanted to ask you, first of all, congratulations on this great study. But I wanted to ask you, the results really focus mostly on forward elevation and external rotation. However, many patients can still struggle with limited internal rotation after reverse shoulder replacement. Can you comment on any differences in internal rotation in regards to variations in component position or size in your study?
Right, so in this study, one of the limitations was that we only chose to look at elevation and external rotation and not internal rotation. And another limitation was that we combined elevation and external rotation in looking at excellent versus poor outcomes. So specifically with regard to internal rotation, no pertinent findings from this study. We just didn't look at that variable, but in my practice, that's certainly one of the frustrations that patients have. Probably their main complaint, if they have any about a reverse, is poor ability to reach up around behind them. So that's something that I try to counsel patients on a lot, and I think that we don't know much about that right now. A larger glenosphere is one thing that's been associated with poor ability to reach behind, and I think we're all trying to figure out if the subscapularis has a role in that right now.
I think it's a great study, Rob. One of the things that I think is interesting and hard to quantify in studies like this is the remaining attached rotator cuff, as just mentioned. Were you able to quantify a status of the remaining posterior rotator cuff as a potential confounding variable for creating more external rotation?
Yeah, that's one thing that we didn't look at in the study as well. I think another weakness is just that this included patients who had a broad range of indications for a reverse. It included, in our database, everyone who had a primary reverse, and we don't really know whether these are intact cuff patients or rotator cuff arthropathy patients, malunion patients. So there wasn't any way for us to determine the status of the intact cuff in this study. We did look at subscapularis repair versus not repair versus unrepaired, and that did not seem to be a risk factor for outcome as it again pertains to elevation and external rotation.
Great. I was curious, Rob, to know, do you think that you would have had similar findings or results with a more valgus neck shaft angle? I know you used a 135 in the study. Can you comment a little bit on that?
One of the cautions in interpreting the study is that this is a single system. All humeral components were 135 degrees, and so that is definitely you don't want to extrapolate these results to a Grammont style, more valgus humerus. In other studies, lateralization in a Grammont system has been associated with poor elevation. And so I think we need to be really cautious about over generalizing results that are based on one specific system.
I think that's really important, as you said. And I think the last thing I wanted to ask you, or really a question I wanted to get your thoughts on, were how have these results changed your practice, or have they? I mean, is everybody now a 42 glenosphere, even a smaller patient, or how do you make that decision in your practice at this point?
Yeah, great question. So when I started my practice, I was using a different system which had much more lateralization. This particular system is either 0 or +4 lateralization from the glenosphere. When I started my practice, I was using a minimum of +6 or +10 for most primary reverses. I've now, and that was with much smaller glenospheres, 33 or 36. Now I'm using a system where I, again, have the option of a lot of lateralization. So I've in general been using smaller glenospheres again. And this has made me worry a bit that I should be increasing the size. However, again, it all depends on the specific system. So I think that there's evidence that smaller glenospheres are just fine with more lateralization. But in this, I think that in a 135-degree system, if I had only the option of 0 or 4, this would certainly make me hedge towards using a larger glenosphere. Hopefully that answers the question.
Yeah, even for a smaller patient.
Even for a smaller patient, yeah. Again, in this particular system, since it's inlay, the humerus dictates somewhat your options for increasing the size of the glenosphere. But I think that, again, if I was stuck using something that was either +0 or +4 with an inlay 135 humerus, I would probably be, based on the results of this, trying to put in a larger glenosphere, since that was the largest risk factor, which was associated with an excellent outcome.
I think it's such an interesting question you raise, as we have different systems with divergent thought processes as to how they design the implant on the glenosphere side, with more or less lateralization, larger or smaller, inlay, onlay, varus, valgus, humerus. How do these factors all come together? I think your study is a great addition to the literature in that regard to help us understand, at least for this system, if you have these options, this is how you maximize it. Certainly going forward, it's going to be great for us to try and, how do you incorporate that with other systems, with other designs? How do we all converge on some local maxima?
Yeah, and so, if you add the ability to do 3D planning and have a transfer technology to put things essentially wherever you want to, it's really incumbent on us to know where we should be putting things, since we can put a variety of different components where we want, theoretically.
Not just where we should be putting them or where we can put them, but how does where we put them affect muscular tension, and how does that affect not just muscular tension, but muscular tension for that specific patient? And that's going to be a challenge, but I think that your study is a great addition, and I'm thankful to you for coming to the podcast to explain it to us.
Excellent. Thank you.
Thanks, Rob.
I'm here with Dr. Mark Frankel from the Florida Orthopedic Institute. Dr. Frankel, how are you?
Great. How are you?
Doing great. Dr. John Barlow from the Mayo Clinic is here as our guest co-host. John, how are you?
Great. Happy to be here.
We're here to discuss Dr. Frankel's project entitled Acute Surgical Management of Proximal Humerus Fractures, Open Reduction Fixation versus Hemi-Arthroplasty versus Reverse Shoulder Arthroplasty. Dr. Frankel, can you give us a high-level summary of this project?
Yeah, we were interested in looking at the surgical treated fractures that we had done over about a 15-year period between myself and my partner, Mark Mile. And some of the things we're interested in is, could we see a difference in outcome? That was one thing. Could we see a difference in recovery of outcome? And could we see some difference in complication rate?
What were some of the main things you found?
So we had some struggles with looking at our initial question because our outcome data was a little bit sparse. The fracture population tends to be a bit different than the elective population, so we had obviously lost the follow-up, and we didn't have as stout of outcome measures, so we used forward flexion, for example, as our outcome measure. And we did see there was a difference. The fracture patients tended to actually have the best function, and then the reverse, and then the hemis had the worst. We also saw that there was distinctly different populations that were treated with these different modalities. So as one might expect, we found that younger patients that had lower comorbidities, and we used the ASES score, which our anesthesiologists get as a surrogate for health status. They actually did the best, and they typically were treated with lesser severe fractures, and we used a near classification for that. Whereas the arthroplastic patients were older, had more comorbidities, and had more complex fractures. So the patients that were treated with ORIF had the best outcome, reverses were second, and the hemis had the least benefit in terms of functional improvement.
With those outcomes for hemi-arthroplasty, do you think that hemi-arthroplasty still has a role in the treatment of proximal humerus fractures?
You know, I think if it does, it's quite limited. In my personal practice, I don't use it because what I found in previous studies with hemi-arthroplasty, if you can get a perfect reconstruction, you have a pretty good chance of a pretty good outcome. But even in my hands, which at the time I had done several hundred hemi-arthroplasties for fracture, there's a 20% likelihood, even using intraoperative fluoro, that I'd have some malreduction of my tuberosities, and that really swayed the outcome significantly different. So it was a technical issue, and at one point we tried to solve that with different jigs and different implants, but it was never really possible. So a reverse prosthesis is a little bit more forgiving, that if you don't get the tuberosities perfect, patients still have pretty good outcomes.
And that's one of the interesting things I thought about this paper was in some historical series, reverse has a higher likelihood of tuberosity union, and it didn't seem like that was seen as much in this series. Can you comment on what that may be related to?
Yeah, that this series I think started in 2004 and ended like 1999 it started. Okay, so the early reverse prostheses before the FDA were the ones that we used to quote as custom implants, and they were very, very different in their design. In other words, they were cemented, there was a smooth shell, and arguably they did not have the optimal design for fracture fixation. And that was something we actually wanted to look at as a side question, but our numbers were too small because it's fairly obvious with the improved designs we currently have, our fracture union is extraordinarily high compared to the earlier design implants.
So it sounds like the hemi-arthroplasty is dying and reverse is sort of taking its place to some degree. What is your indications currently for open reduction internal fixation, let's say in patients over 60 or 65, or does that exist? Let's say a 2-part fracture or a non-displaced 3-part.
Yeah, I think a 2-part fracture where it's a surgical neck fracture, it's widely displaced, regardless of the age. I think that those patients do really well with an ORIF. And if you're worried about osteoporosis, you can augment your fixation with some bone or other methodology. So I think in that particular fracture type, that's a pretty good operation still. It gets more complicated when you get more displaced of the tuberosities, because once the tuberosities are involved in the fracture pattern, again, the outcome is in ORIF or Hemi, you need to get them perfect, and that can be challenging.
One of the things that I think is super interesting about this study is the high rate of subsequent fracture.
Yeah, that to me was the one thing that I think is a tremendous opportunity for us as a subspecialty society, is to recognize that when we see a patient that has suffered a proximal humerus fracture, even if we're seeing the sequelae of that fracture, that patient has a high risk of having a subsequent fall with a subsequent fracture. And as such, we can intervene potentially at that moment. And there's several articles about fracture prevention and methods to do it. For example, you can work on balance of patients, because you might think that when patients tell you, I just tripped over the cat or the rug, or and it seems perfectly plausible that this is a one-time event. It turns out statistically these people are just much more at risk of having subsequent falls with subsequent fracture that can impact their overall health status tremendously, especially in the elderly. So I think it's a great opportunity for us to develop protocols that when you see a patient who's sustained a proximal humerus fracture at any point, that you think about sending them to PT to work with balance. You have them see their internist or their doctor to work up their metabolic bone profile, because osteoporosis certainly can be impacted. And there are probably other features that really could be investigated, because there's a lot to falls that in the elderly particularly that we just don't know about, and it'd be nice to collaborate with maybe rehabilitationists or therapists to help us be much better at preventing subsequent falls and subsequent fracture.
Well, it's a great project. For us, it gives us so much insight into the outcome of the different treatments, but then also this window into an opportunity for prevention of future injuries. So thank you so much for doing this with me. I really appreciate it.
Great, guys. That was awesome.
So I'm here with Dr. Rapper Hudek from Germany. Dr. Hudek, how are you?
I'm fine.
I should preface this by saying that we've had a technical issue, so this is our second time having this conversation, but we're going to get it right this time. Dr. Eric Ricchetti is here from the Cleveland Clinic as our guest co-host. Eric, how are you?
Great, Peter. Thanks for having me.
Thanks for doing this one more time with me. We're here to discuss Dr. Hudek's project entitled Cutibacterium acnes is observed as an intra-articular and intracellular commensal of the human shoulder joint during first-time shoulder surgery.
Dr. Dick, can you give us a high-level summary of your project?
Yeah, so first of all, thank you very much for inviting me. It's a big honor for me, and it's the first time on ASES meeting, so it's really great to be here and to talk to you. So our study was about the occurrence of C. acnes in histological specimen because as you might know, we find C. acnes in first-time shoulder surgery in healthy patients a lot. So there's always the same discussion whether it's a commensal or contamination or a true infection. So, and simultaneously we know that in cell culture, C. acnes can hide in macrophages and stay there for a very long time. And even in other human tissues like the prostate, it has been found intracellularly, so we were curious about looking at first-time shoulder surgery patients and to harvest tissue specimen and to look whether we can find C. acnes in intracellular position. So we took specimen from these patients arthroscopically and in open surgery, and we stained them with specific immunohistochemistry and specific C. acnes antibodies. And we find it in more than half of the patients in an intracellular position, and the most of them were found in the AC joint, and a quarter of the patients would have been undetected by culture because we did also microbiological culture, but the sensitivity of immunohistochemistry was much better, so we found it in almost 70% in immunohistochemistry and only in 43.5% in culture.
So now tell us, how does the fact that this is intracellular make you know that this isn't, how do we know this isn't just lab contamination or contamination of the surgical field during the procedure?
Well, that's a good question because we know that in cell culture, if you take macrophages and you mix them with bacteria, they can reduce the amount of bacteria by half in 9 minutes. So they're pretty fast in cell culture. But it's a completely different situation in a real life setting. And because the time between grabbing the tissue specimen and putting it into a formalin container was very short, under a minute. We took it over an arthroscopic cannula to go around contamination, and the time is pretty quick, so we believe that there is less risk of contamination. And if there would be, we would suggest that the contaminant bacteria would gather at the edges of the probe, which was not the case. So it was in the middle, in the center, and everywhere. So when you take something with your instrument, you contaminate it, you would just contaminate the edges, and that was not the case. So I am not sure, but it is unlikely that it has been contaminated.
And Robert, as a follow-up, it's very interesting that we're seeing this bacteria intracellularly, and these are first-time surgeries, so we don't really think these are cases of true infection, but how do you think this information may relate to a clinically relevant infection in someone who may have this bacteria intracellularly? What actually triggers the response of an infection, let's say when someone has a shoulder replacement? And do you have any sense of that with this data?
Well, it's difficult to answer. We do not really know what's going on, but we know that the bacterium can reside in other human body parts like the prostate or the spine or lungs and lymph nodes and so on, and it can stay there without harming us. It is just there, and there's research groups from Japan who hypothesize that, for example, sarcoidosis is just the reaction of our immune system to an intracellular commensal, which is C. acnes. And it is only affecting people who have a hyperreactive immune system to this bacterium. So it might be that when we see a low-grade infection in shoulders, that it is just a immunological trigger we don't know of, like stress during operation or stress at a much later time point, which makes the bacteria, which are already inside the joint, grow and replicate, make biofilms and stay there on the implant. But on the other hand, We know that we also displace them from the upper parts of the skin, from the sebastiofollicular unit. We know that, and maybe it's also a question of when different subtypes of bacteria mix up. So the subtype from the deep gets in contact with the subtype from the superficial part. Maybe this is a problem because they maybe try to they try to fight and to maintain their place where they stay.
So actually, why don't you talk about that a little further too, because you did some very interesting things in this study looking at types of C. acnes and what that might also mean for infectious potential.
Yeah, so this is also this has been interesting to us because we know that there's 5 different subtypes, and when you look at their genetic profile, you see that they are capable of doing different things. So, and other colleagues found type 2 in the deep tissues as well as we did. So it was the predominant type of the deeper areas, and it was also linked to periprosthetic infections. And the interesting part about type 2 is that it is the only subtype which has a CRISPR-Cas system, the genetic scissors, which all the other subtypes don't have. So maybe there's a key to determine whether there's a more aggressive type or not. The second point is type 2 is called type defendans because it has these pili, like little arms, which makes it better connect to others and better connect to surfaces. And this has been shown in the prostate very well. So it might be that we're heading into the direction that subtype 2 is the one we aimed at, but I cannot tell that for sure. It's just a pure hypothesis on our data, but we will definitely look further and dig deeper into this issue.
And clinically, there's nothing we can do right now to differentiate subtypes. Right? There's no clinical test I can use to determine whether what's growing on my culture is subtype 2. That's for research use only, but maybe someday we will have that.
Well, right now, the typical methods of differentiating subtypes is genetic sequencing, so single locus type sequencing, or if you want to make it much more sophisticated, you do multi-locus type sequencing. Mm-hmm. But there's also easier methods of subtyping if you take the mass spectrometry. So there's also protocols on how to use mass spectrometry and to differentiate subtypes. Mm-hmm. So this is a cheaper and quicker method of doing it, but it is not as reliable as a single locus type sequencing. So this has to be done by experts in a microbiology lab who know about sequence typing.
Do you think, there's been some evidence in the past that there may be differences between patients with and without osteoarthritis in the prevalence of culture positivity at the time of the initial surgery. Do you think that it's possible, based on your findings, that P. acnes plays a role within other pathology, like within the etiology of other pathologies we see in the shoulder?
Yeah, that's an intriguing question, and sometimes I think that we only see the tip of an iceberg, because in our data we found the most prevalent site was the AC joint. So the most of them we found in the AC joint, and you know how close the AC joint is to the skin. It's not so far away. So we could hypothesize that it just gets a little bit deeper into the joint and stays there. And the other point is, if we see osteoarthritis, there's so much inflammation. You see macrophages very actively, and you see lots of interleukins and markers and chemical signals of inflammation. So why is this inflammation happening in osteoarthritis? But it could be a possible explanation, but this will be the next research question, whether we could link the presence of an intra-articular commensal to osteoarthritis.
Tantalizingly, AC osteoarthritis is way more prevalent than glenohumeral osteoarthritis, which mirrors the findings of your study in terms of the prevalence of in this intra-articular commensal and C. acnes.
Robert, how about any next steps in terms of the follow-up to the study? Are you planning on looking at similar techniques in revision surgery, for example?
Well, so we are about to look at symptomatic patients versus asymptomatic patients, because we see a lot of patients with completely asymptomatic situations. When you take out clavicle plates, for instance, and you take specimen and you do cultures, you find C. acnes very, very often. But these patients, they have no problems at all. And simultaneously, you see a lot of patients in revision surgery which have early loosening, pain, stiffness, scarring, lots of symptomatic trouble. And you also find C. acnes. So we are looking to differentiate in the European multicenter study right now whether we can find any subtype differences in these two clinically different types of patients. Mm-hmm. So that's the study right now going on, and well, we are very happy to share knowledge and to stick together to combine the European experience with the American experience. I think you guys are the pacemakers in this field, and you have a very great group and looking for diagnosis and how to manage this, let's say complex but intriguous problem right now with low-grade infections.
Well, I think that this study is such an important contribution to our understanding of C. acnes and its role in the shoulder, and certainly I think it's going to have implications for us going forward as we continue to put metal implants into a joint that may have a bacteria that lives naturally within it. I can't tell you how much I appreciate you coming on the podcast and sharing this with us. Thank you, Eric, for your help as well.
Thank you for having me, Peter. Thank you for coming, Robert.
Thank you very much.
I'm here with Dr. Shawn O'Driscoll from the Mayo Clinic. Dr. O'Driscoll, how are you?
I'm very well, thank you. How are you today?
Doing great. Dr. Brandon Erickson from Rothman is here as our guest co-host. Brandon is on the phone. Brandon, how are you?
Hey, doing great. Good morning, Peter.
Good morning, Brandon.
We are here to discuss Dr. O'Driscoll's project entitled CT Reveals Additional Important Information for Preoperative Diagnosis of Capitellar Osteochondritis Dissecans Compared to MRI. Dr. Driscoll, can you give us a high-level summary of your project?
Yes, I'd be pleased to do so. Thank you. Well, in patients with osteochondritis dissecans of the elbow, very often they present at a time when the lesion is already quite advanced, and so treatment options start to become more narrow. And if we could get to this at a little bit earlier stage and understand its diagnosis, as well as understand better how to categorize it preoperatively, we would have perhaps a little bit better method of approaching the problem. And fundamentally, this work is about the concept that osteochondritis dissecans of the capitellum is a problem of the subchondral bone. The cartilage changes are secondary. And when we image bone for any reason whatsoever, we always consider that CT is the imaging of choice in terms of the definition and quality of the imaging. But with but with OCD of the capitellum, it's very common that imaging that's used as an MRI rather than CT. At our institution, we've used CT routinely for many years for this condition. And so we did this study to compare the efficacy of CT and MRI in evaluating OCD of the capitellum. Many of the patients whom we see, even though we order a CT, will have already had an MRI. And so we identified a cohort of patients who had had both MRI and CT scan, which was a total of 28 patients and 29 elbows, and then compared the CTs and MRIs with the hypothesis in mind that CT would reveal additional information not readily apparent through MRI imaging. And in fact, we did find that. We found that the cleavage plane under the OCD lesion is more readily identified on CT scan, as is fragmentation of the actual lesion itself. And then secondary changes in the rest of the joint, such as osteophytes or small loose bodies in the ulnohumeral articulation, and especially the degenerative changes in the rest of the joint, are more readily detected in a clinically significant and statistically significant difference using CT compared to MRI. So when we think about looking at the problem in terms of the defect, the fragment itself, the rest of the joint, CT gives us added value over MRI. And we did not find any deficit using CT instead of MRI. And thus, CT has become our imaging of choice. And we recommend CT routinely as the for osteochondritis dissecans of the capitellum.
Now, were there any findings that you found in MRI that you didn't find on CT? Are there any indications still in your mind for when you would also still obtain an MRI for assessment of the periarticular soft tissues?
Well, if we specifically want to look at the periarticular soft tissues, then there's no question MRI is the imaging of choice. Most patients with OCD of the capitellum, and we're talking about the adolescent age group, do not necessarily have something of concern in the soft tissues as well. And so if we believe that we're looking at an isolated condition, we would only do a CT scan. If it's a baseball player and we're thinking that there might be a problem at the medial elbow as well as at the capitellum, then MRI would play a role in evaluating those soft tissues, of course.
So for you, that's a physical exam finding preoperative?
A physical exam, if the patient has pain at the medial side of the elbow, physical examination will tell you whether or not you're concerned about something there. And I would add that let's say that we have some concern about the integrity of their UCL at the medial elbow. Let's say a 14-year-old baseball pitcher with pain at the capitellum that is probably an OCD lesion, pain also at the medial side that makes us think that they might have a UCL problem. Clinical exam with a moving valgus stress test would make us suspicious of that or not. Then an MRI will certainly tell us about the ligament on the medial side of the elbow better than a CT would. Mm-hmm. On the other hand, if in that young patient we're concerned about an apophyseal injury or a small bony flake avulsion from the epicondyle itself, then CT is better than MRI if we're looking at that.
Mm-hmm.
So, Dr. Distal, just wondering, what was the driving force behind why you conducted the study? Were there patients that you had MRIs only on that came in that maybe didn't have a CT that you maybe operated on, didn't operate on, that you maybe would have treated differently, or what was kind of the reason you conducted the study? Were there a few patients that you didn't like the way they were treated, or just kind of wondering?
Yeah, very good question. Thank you. The driving force for the study is to educate surgeons who treat these patients that unless they're doing CTs, they may well be working with only part of the information available to them. So it's not unusual that I will treat patients who have already been operated on for OCD of the capitellum, but who never had a CT. And once we get a CT scan, we understand why the patient is still symptomatic and treat that particular finding, and then the patients do well. I'll give you an example of a patient recently referred to me by a colleague who's a very highly respected sports surgeon nearby, had treated a patient who was a young pitcher and athlete in a number of sports who had an 8mm OCD lesion that he went in and debrided, and the patient simply never got better. He had 2 additional MRIs post-op. They were thought to not reveal anything surgical at all. And he referred the patient to me. And on the phone, I said to him that I'm going to do a CT scan because the CT will reveal fine, detailed bone changes that the MRI might not pick up. You see, a CT scan is a 0.6mm slice interval imaging study, whereas 3mm cuts are kind of standard for MRI. So having said that, this patient still had a fragment of subchondral bone detached from the capitellum itself at the margin of the defect. So the defect was thought to be about 6 by 8 millimeters. In actual fact, the defect was more like 10, I think it was, or a bit more millimeters. And there was a retained fractured fragment at the edge of the defect, which I removed surgically. And within about 3 weeks, this young lad was back skiing fully without pain. We also imaged his other elbow because it had been symptomatic for about a year as well. And he had a lesion in his other elbow as well, which required surgical intervention. So yes, the purpose was really to educate surgeons who are seeing this condition to use CT scan for the purpose of evaluating it. And another concern is how do we determine if the lesions have healed if we have treated them with some method of trying to get them to heal, such as drilling or fixation. And I believe that we cannot tell from MRI, but we certainly can tell if the bone is healed from CT scan. So CT is the imaging of choice in determining at final follow-up whether or not these are healed and the patient can go back to their high-level sport that would cause significant stresses.
Were there some lesions that you looked at on MRI and CT where your decision as to whether or not it might be fixable with some sort of fixation might have been swayed by getting a CT scan, where maybe there was more bone on the backside of the fragment than you might have otherwise anticipated in an MRI?
Yeah, great question. Yes, it happened both ways. Where in one particular case, one of the lesions was displaced and the fragment was up in the coronoid fossa, but it had a single piece of subchondral bone, wasn't fragmented, and it was in fact a couple of millimeters thick. That one we determined preoperatively was almost certainly going to be fixable, and we did. We reduced that and fixed it. On the other hand, we sometimes have seen lesions sitting in situ. The bone is very, very thin, less than half a millimeter perhaps, and fragmented and tilted. And we know that such a fragment as that is really only cartilage with a tiny bit of bone, if you like, in the base of the cartilage, and not amenable to any form of fixation other than at most suture fixation across the top of it. So yes, it does have an impact on our surgical decision making in such cases.
And Dr. Distal, I was wondering, we obviously orthopedic research is difficult, and we do a lot of, kind of retrospective studies, case control, cohort studies. If you had done this study prospectively, do you think your results would have been the same? Do you think, having both scans on every patient rather than going back and just picking out this select group, do you think you would have found the same things? Do you think you would have had different findings? How do you feel about that?
Well, it's a good way to look at it. A very carefully performed prospective study, I think, almost always reveals information or confirms or refutes information that otherwise might be thought to have been garnered from a retrospective study. So it would be likely indeed that we would learn something of value from a prospective study. To answer your question fully, I realize that it brings me back to the first question you asked, which was about what really got this study going. And I realized that what got the study going more than anything else is that despite seeing MRIs on so many of these patients, as well as CT scans that I would order, I realized that there were things that I was looking for on the CT scans preoperatively that I could not tell from an MRI. So, for example, if a patient comes to me and has a 25 or 30 degree contracture of the elbow and an OCD lesion, I now realize that the surgical decision making that I go through involves looking on the CT scan for evidence of an inflammatory, possibly autoimmune reaction inside the joint generally in response to the OCD. Now, for example, that patient, I would anticipate almost for sure finding evidence of early osteophyte formation in the ulnohumeral joint. And that osteophyte formation would be associated almost certainly intraoperatively with the finding of pannus-like lesions growing onto the articular cartilage on the margin of the trochleum and synovitis, distant from the lesion itself. That tells me that that patient is responding biologically inside the joint to a mechanical problem in the capitellar. And in such circumstances, I think that it's essential that we do not permit that mechanical disturbance to continue, because that particular patient is at risk of an ongoing biological response, which is harmful. And some of these patients will get, as I'm sure you're aware, very significant contractures. Another finding that I look for is a sign of findings of active osteolysis underneath the lesion. So if you do a CT scan, you may see rounded osteolytic lesions in the base of the defect itself. And this is a sign not of mechanical erosion of the subchondral bone under the fragment, but of active osteolysis in response to the instability of the fragment itself, much as you see active osteolysis at a non-union in some patients as well. These are well seen on a CT scan, very, very well, but are not very easy to determine on an MRI. And so these are some of the findings that I go through the CT scan looking for preoperatively that would impact my decision making. So if we were doing this study prospectively, I believe that we would in fact confirm or prove that such findings are able to be recognized on CT and are either going to be very difficult to recognize on MRI or maybe only quite apparent once we already know what the CT scan showed. I don't think we would see it as well on MRI.
It also sounds as though you obtained a CT scan on every OCD over a period of time.
I do, yes. I routinely get it on everybody.
So this, it's not as though you selected a cohort of those that looked bad on MRI and only CT'd those patients. You got a CT on everyone.
That's
So
quite correct. I get a CT scan on every single patient without exception. And the MRIs, I don't believe I ordered MRIs in addition to CT on any of these patients. These are patients who came to me, referred by a colleague, maybe within the institution, they already had the MRI, or referred from outside by a colleague and they've already had the MRI. But the MRIs had to be within a reasonable time frame of the CT scan, so that they were not, distant in time. And that eliminates some.
but with that design, I think it's less likely to introduce that kind of selection bias that you might worry about with this study design and elsewhere.
Yes, this is not at all whatsoever a selection bias type issue, because everybody CT.
Right.
The only question is, if the patient came to me directly, the patient did not get an MRI, so there is a selection bias that way.
Mm-hmm.
But yeah.
Well, Dr. Driscoll, I think this is a great study. I think it's a great addition to our understanding for how we diagnose and come up with the proper indications for treatment of OCD lesions. And I can't tell how much I appreciate you coming on the podcast and explaining it to us. Thank you, Brandon, for serving as our guest host.
I appreciate
No, it's fantastic. Thanks for including me. It's very nice to meet you, Dr. Driscoll. This is a very interesting study. I will now be ordering CT scans for all these patients for sure.
Practice changing for sure.
Thank you very much. Can I add one final point?
Absolutely, please.
And that would be that if you have a patient who is in the at-risk group, that would be a young baseball pitcher or catcher, a weightlifter or a gymnast, possibly a tennis player, and they have pain in the lateral elbow joint, and they've had pain for, say, 10 days in their sport. If you do a CT scan and pick up this little crack in the subchondral bone, it'll be while it's only a stress fracture. It's not yet a stress fracture non-union. You protect that and mobilize that for 3 weeks, bring them back to sport gradually for over another 3 weeks, and that'll be a healed stress fracture. It will not evolve into, a non-union over time. And with time, we'll have to develop a non-radiation based method for imaging these. I'm sure that will be possible in the future. We're doing work on it. Others, I'm sure, will be as well. But for the moment, if I have such a patient, I get a CT scan because I don't want that to show up as a non-union 4 months or 9 months from now. I'd rather get it while it's just a crack in the bone.
Certainly, if a CT scan helps you to avoid a surgery, it would be worth the small amount of radiation that an elbow CT is as compared to, say, a CT of the body.
Exactly.
Yeah.
Thank you.
Thank you again. Great.
Take care, Dr. Driscoll.
And that's it, folks. Thanks for listening. Thank you to all of our guests and guest hosts. For all our shoulder and elbow listeners out there, don't forget to subscribe, and we'll see you next time.